updates in treating tobacco dependence in mental health settings. And so we're switching gears a little bit to other kinds of disparities. Tobacco use in patients with mental health and substance use disorder conditions, and the disproportionate impact of tobacco on this very vulnerable population. North Carolina's state-operated facilities went tobacco-free many years ago, and there are a number of tobacco initiatives and programs underway that have made a lot of progress, but there still remains a lot of work to do. So our speaker today is Dr. Jill Williams. She's a professor of psychiatry and director of the Division of Addiction Psychiatry at the Rutgers University Robert Wood Johnson Medical School. She also holds faculty appointments at the Cancer Institute of New Jersey and the Rutgers Center for Alcohol Studies. The focus of her work has been in addressing tobacco in individuals with mental illness and/or addiction through treatment and systems interventions. She serves as the chair of the APA Council on Addiction Psychiatry. She will talk about updates in treating tobacco dependence in mental health settings. Welcome, Dr. Williams, and we appreciate your flexibility.
No problem. Good morning, everyone. Thank you for this invitation. It's a pleasure to be here, and I'm enjoying the conference so far and learning a lot. So it's really been my pleasure to be here. I just want to shout out to my friend and mentor, Dr. Roy Stein. In fact, I have a very long relationship with Governor's Institute. I trained at Duke back in the 90s, and it was the first grant I ever got. So it's really nice to be back again with all of you today. That's just my disclosure information, and I'm going to talk a bit about the co-occurrence of tobacco with mental illness and populations with other addictions, discussing the consequences of use, and talk about reduced access for services among this population, as well as a review and updates in treatment. So you might be surprised that the cigarette smoking rate is really at an all-time low in this country. Estimates are less than 14% of Americans currently smoke cigarettes. That number continues to decline at about 0.5% per year. But there are disparities even between the states, and a state like North Carolina actually has slightly higher than the national average with about 17%. But really my emphasis has been in populations with mental illness or substance use disorder, where you can see rates are 2 to 3 times higher than the general population. This has been shown consistently across many studies. And it is concerning that tobacco use rates continue to be highest among those with an alcohol or drug use disorder. This is just from the recent Surgeon General's report that came out this year on smoking cessation. Another way of looking at the data in terms of using the K6, which is a population measure for serious psychological distress, again confirming higher rates of tobacco use in those with serious psychological distress, which is a population estimate measure for serious mental illness. But you see also the role of socioeconomic status continues to be important in understanding who is at risk for tobacco use, with higher rates among those with lower education, as well as poverty status. So we can really think about this as a social justice issue. Now that so many Americans have stopped smoking, it seems to affect our most vulnerable populations to a greater degree, not only those with mental illness, but LGBTQ populations. As was mentioned already, there's a disproportionate advertising and marketing to certain vulnerable populations, with evidence of more tobacco ads, for example, in Black neighborhoods. Despite the decline in tobacco use, it's still surprisingly the #1 cause of preventable death in the US, causing more death than any other reason. Tobacco use is linked to at least 30% of all cancer deaths, which is really a significant percentage. It causes all the cancers listed on this slide in orange. So think beyond lung cancer, as well as many other chronic diseases. In terms of the recent COVID pandemic, there have been many studies that have linked being a smoker to a worse outcome in terms of greater risk for not only contracting the virus, but having a more severe course and more likely to be hospitalized. There was some conflicting evidence that came out with different studies that were on the news, but the CDC has put up an update as of yesterday, confirming that being a current or former cigarette smoker increases your risk of severe illness from COVID-19. Some of the discrepancy had to do with nicotine itself, which may have a small role as an anti-inflammatory. And there's some evidence that nicotine, at least in some animal models, could have this effect in reducing the risk for cytokine storm, which of course is the most serious consequence of COVID. However, really the risk-benefit ratio would support that if there is a potential modest effect from nicotine, that would still support using nicotine replacement medications, since there are many risks from tobacco, and the risk-benefit ratio would support the use of nicotine over tobacco, since smokers also have other comorbidities that raise your risk, including cardiovascular disease and lung disease. So this is an old saying, but kind of a good one. It's the smoke that kills, because it helps us remember that the bulk of toxicity really is in the smoke. Cigarette smoke contains thousands of different chemical compounds, most of which are toxic to the human body. Nicotine, of course, is one of those chemicals, but it's not the one that we get diseases from. In fact, if you think about the three big types of diseases that we get from smoking, it includes cancers, heart disease, and lung diseases like COPD. In fact, none of those are linked to the nicotine. We get those diseases from all of the other toxins and chemicals contained in cigarette smoke, which is estimated to contain more than 65 carcinogens. So in substance abuse treatment settings where I've done a lot of work, people talk about smoking as harm reduction. It's better than using other drugs, but in fact it is more lethal. So not clear that that would actually reduce harm. In terms of understanding where those chemicals come from, it's important to remember that nicotine, of course, is naturally occurring in the tobacco plant, but there's something else in the plant called nitrosamines, and nitrosamines are a very potent carcinogen. That helps underscore that all forms of tobacco carry the risk for cancer, because essentially the carcinogens are in the plant. There are chemicals added during cigarette manufacturing, things that change the way the tobacco smells or burns or tastes. But in fact, most of the chemicals come from when we light tobacco on fire. That creates thousands of new chemicals and many and most of the toxins, including carbon monoxide. Just to shift a bit from the health consequences, in some ways, these consequences may be more important to your patients in an immediate way. Tobacco impacts really every aspect of life, and I would argue it's a barrier to recovery and living successfully in the community. It's quite expensive to use tobacco, so there are financial hardships. It's harder to get a job if you're a smoker. It's maybe harder to secure housing. It's associated with a worse mental health. It's sort of a myth that smoking treats mental illness, and that's been really disproven at this point. If you're a tobacco user, you're more likely to relapse back to drugs and alcohol. So similarly, it's related to worse outcomes. There's the stigma in being a smoker. There's poor appearance like wrinkles and other effects, and it's the #1 cause of lethal fire in the home. So many ways that it impacts people, and in some ways these may be more relevant to people in their everyday life in terms of talking about consequences to help motivate people. In terms of national and state public health interventions, this is referred to as tobacco control. These techniques have been studied for decades and are effective. They include things like anti-smoking advertisements, increasing the price of cigarettes by increasing the cigarette tax, which is also a successful way to help people to stop and also to keep teens from starting. Similar age restrictions. Tobacco-free laws and policies have been very successful in terms of changing the norms around tobacco use and protecting tobacco-free air. Keep in mind, for many years, behavioral health facilities were exempted from those laws, which in some ways is a kind of reverse discrimination, as well as support for cessation and treatment. How are we doing in this country in terms of addressing tobacco in our behavioral health facilities? This is fairly recent data. This study was done by the CDC in 2016 and published in 2018. And it's quite striking in showing that less than half of US mental health treatment facilities even ask or screen for tobacco. That's pretty staggering that we don't even ask half the time. And you could imagine that if you don't ask, the rates of intervention would be lower still. Substance abuse facilities score essentially the same. So we have a long way to go in terms of routinely offering this in behavioral health treatment. And as I mentioned, there's now been considerable evidence that when people stop smoking, their mental health gets better. This was a meta-analysis of 26 studies, which showed that when people stop smoking, if you evaluate them 6 weeks to 6 months later, you can show evidence that anxiety and depression go down, stress goes down, quality of life and mood are improved. It's important that I say that the assessments are done 6 weeks to 6 months after people stop smoking, because as you can imagine, no one feels better the first day. That would be true for any substance use disorder, that people typically don't feel better on the first day that they quit, but they feel better over time. And that same trend is true for tobacco. It's always important to remind people that tobacco use disorder is in the DSM-5, and the reason that it's in the DSM-5, of course, is because it's an addiction. I started doing this work as a psychiatrist specializing in tobacco more than 20 years ago. And I think we've come a long way in people sort of accepting that this is an addiction, but it wasn't always that way. We have strong biological evidence that nicotine activates the brain reward pathways, much in the way of heroin, cocaine, and other drugs, and meets every criteria really for being an addiction. In fact, when you think about route of administration, that's an important characteristic in understanding the relative addictive potential of a substance. And when you smoke a drug, in fact, you get the most rapid delivery of drug to the brain, which is an important property in understanding how addicting something is. Sometimes people are surprised to learn that in fact, smoking a drug is comparable to shooting up IV in terms of its addiction potential. But that's because the lung has a huge area of vasculature that can absorb a large amount of drug almost instantaneously. And it's a very short distance from the lung to the brain. So it ends up being a good, although highly addictive way to deliver drug to the brain, and helps underscore one of the reasons why smoking is so addicting. In terms of clinical information, I like to teach people sort of the quick and dirty way to do this, because I recognize that people are busy and have many other things that they need to accomplish. So in terms of assessment, there's one question that's probably better than all others in terms of understanding someone's level of addiction to tobacco. Ask people how many minutes in the morning until they smoke their first cigarette. This is referred to as TTFC, or the time to first cigarette. It's a highly sensitive measure for understanding level of addiction. Nicotine essentially has a short half-life of just a few hours. People go into withdrawal from this drug within hours of their last cigarette, and they essentially wake up every day of their life as a smoker in drug withdrawal. The faster they reach for the cigarette, the more addicted they are, and this is a very helpful clinical measure. Anyone that smokes in the first 30 minutes of waking up is at least moderately nicotine dependent. That's a good crude estimate that the person is likely going to need medication. Without medication, they would have a lower chance of being able to quit smoking based on the amount of withdrawal symptoms that they would likely experience. As we ask patients in mental health and addictions treatment sites this question, many in fact report that they smoke in the first 5 minutes of waking up, which is an indicator of the highest or most severe levels of nicotine dependence. So this is an important prognostic indicator because the more severe your addiction, the harder it is to quit. Again, it has implications for medication as well as dose and perhaps intensity of treatment. Studies are now showing, in fact, people wake up in the middle of the night to smoke. They don't even make it to the morning, which is a higher level of dependence in terms of an indicator. And as I mentioned, there's been many studies that have demonstrated that people in either addiction treatment settings, which is the top graph, the other one is showing population data, smokers with depression. Many of these studies have shown that these populations have a greater severity of nicotine dependence compared to populations without mental illness. This is some research we did that showed that even on a single cigarette, individuals with schizophrenia smoke in such a way that they're able to take in more nicotine per cigarette in the way that they smoke, and clinically they're among the most heavily dependent groups that we see. I mentioned that within hours of your last cigarette, someone can be experiencing the symptoms of tobacco withdrawal. These can last for weeks at least after quitting, and can include things like sad or depressed mood, insomnia, irritability, anxiety, trouble concentrating, restlessness, feeling hungry, and intense urges or cravings to smoke. This is a real withdrawal syndrome, but none of the symptoms are so specific. That makes me think it's missed in a lot of clinical settings. And as you can imagine, in the psychiatric hospital or other places where people are unable to smoke, some of these symptoms, because we're not recognizing this as tobacco withdrawal, we could be treating potentially these symptoms not with nicotine, which they would respond to, but actually to much more powerful and potentially dangerous medications. You can also understand here how people sort of fool themselves into this idea that they need to smoke because it reduces their anxiety. Within hours of your last cigarette, you would actually be experiencing increased anxiety as a result of tobacco withdrawal. And the best way to get rid of withdrawal symptoms, as you know, is to use the drug. And so there's not a real benefit in terms of anxiety and depression. It's merely that people are just putting themselves out of withdrawal. So why is it so hard to quit? Well, we mentioned one of the reasons is that smoking a drug is highly addicting in terms of delivery to the brain, highly reinforcing. In addition, when we think about treatment for tobacco, it's quite limited. There's only a few medications which are FDA approved. Most people get a minimal counseling support if they get it at all. And there are no levels of care. In fact, some people say to me they wish they could go to rehab to stop smoking, but it doesn't exist. In addition, the utilization of the treatments we have is poor. Again, most people won't use counseling, or they may use medications at too low of a dose or not enough time. So this is just to point out that although access to all substance use disorders is quite poor, and around 15%, as we learned in the earlier presentation, it's less than, even for tobacco, it's less than that when you think about people that use the free telephone quit line. It only reaches 1% of smokers. And again, there really are no ASAM levels of care for tobacco. Even if you're quite ill, even if you have cancer, even if you failed treatment 50 times, we really don't offer people anything more than a level 1 treatment. What are the predictors of successfully quitting smoking? Unfortunately, it's a lot of features that are the opposite of the patients that we see. So having a lower level of dependence makes it easier to quit, having a higher socioeconomic status, having an older age, having a male gender. So now there's some new evidence that women do struggle more on a given quit attempt and have slightly less success in quitting. Not having a behavioral health condition makes it easier to quit, having fewer smokers in your social network. And importantly, the use of treatment is probably the most important one on the list in terms of one that we can really directly impact. So the message to patients isn't you ought to quit smoking, it's you ought to quit smoking with treatment, because treatment will greatly increase the chances that you will be successful. Just a bit about gender. Again, this is fairly new research that suggests that women in a given quit attempt may be less likely to successfully quit smoking than men. Not exactly known what's behind this. Some of the theories could be perhaps greater mood changes. There could be socioeconomic issues, which are factors. Perhaps women are less likely to use meds in treatment. So it's not been teased out yet what this represents, but does seem to be a true difference. And it also has some implications in terms of medication, because there's some evidence that preferentially women may do better with Varenicline. In men, in this analysis of looking at effectiveness of Varenicline versus patch, it didn't matter, but for women, there seems to be some advantage in Varenicline treatment. Again, early research, not completely understood, but quite interesting. So what's new in this field? Well, messaging certainly is new in terms of how we talk about it. We want to talk about it as treatment and normalize it in the context of everything that we do. There's alternatives, which are maybe more harm reduction strategies that I'll briefly talk about. I think there's a role for more aggressive pharmacotherapy. There's also been a movement for greater access for pharmacotherapy across the country in recent years in terms of Medicaid expansion. It's really helped those efforts, as well as improving access to these OTC medications and allowing people to get them through their state Medicaid. There's some new research about selective pharmacotherapy for different groups. I won't say much about that today, but that's an area of research that's actively going on. And then, of course, there's been a great increase in so-called lower risk products that may heat nicotine, but technically don't burn, the non-combustibles that I'll say a little bit about. So anyone who's ever heard me speak knows that this is pretty important to me. I started in co-occurring disorders, and tobacco use is also a co-occurring disorder. It was sort of not included in the original models for co-occurring disorder, which don't make any sense to me. And we should really approach it the way we approach all other types of co-occurring problems, where we know that not everyone may be immediately ready for abstinence or may not be motivated to quit, but we don't give up. We still work with people in an integrated way using a long-term treatment perspective where we give different interventions based on people's motivational level. This model says that when all else fails, we can always do assessment. Interestingly, pharmacotherapy can be an important part. And so this model really works well for tobacco, I feel. And in fact, some of the best studies of co-occurring disorders have shown that when you include the wraparound services like case management and housing, people really do much better. And so I can look at a model like this and say this seems to work completely well for tobacco. Similarly, I would say we should stop calling it tobacco cessation or smoking cessation. I'm not a big fan of the word. It confuses people. It has a lot, it's sort of emotionally charged in terms of really having to do something. And calling it treatment would be much more consistent with our motivational approaches of trying to engage everyone in some way. Similarly, these are sort of new ways of thinking about this. Why not quit for a day? Why not quit for a few hours? What have you got to lose? I encourage patients, why don't you try my nicotine instead of your nicotine? Chances are my nicotine will be free because you can get it often for free through the Medicaid formulary. You could give it a try. You could tell me what you like about it, what you didn't like. You might feel better. You might be able to practice an alternative coping strategy. So lots of reasons to sort of give it a try or even engage in what's called a practice quit attempt as a way to get people more interested. There are some new emerging models like this one, the opt-out tobacco treatment model, which people are starting to investigate in a hospital or other clinic setting. The idea is to just present tobacco treatment without asking people if they want it. So again, this has been studied so far mostly in hospital settings, but also in cancer clinics and prenatal clinics. So basically to provide a bedside consult to all tobacco users. Sometimes they've even used that opportunity to directly call the quit line together, hand the phone to the participant as a way to help do what's called a warm handoff in terms of enrolling and counseling people. When you do these kinds of more aggressive strategies, of course, the person has the ability to opt out or refuse. They always do, but it turns out that very few do, only about 15%. And these approaches have been associated with increased use of medications, as well as increased abstinence rates after discharge. The Quit line, of course, is another service that's available now in every state. It's typically free or low cost. It's telephone delivered counseling. It often includes an assessment call as well as a series of follow-up calls after the person makes a quit attempt. It's often provided in many languages. It's great because you don't have to worry about transportation. It is associated with success and sometimes offers a free nicotine replacement as part of the service. Now I'm going to shift and talk about medications, which are really an important part of helping people to stop smoking. In fact, this is sort of the original MAT. These medications are cost effective. The primary way that they work is by reducing or eliminating the uncomfortable symptoms of tobacco withdrawal. But that's not the only effect that they have. They also block the pleasure associated with smoking and lessen the weight gain associated with quitting. We say that these medications increase the chances that someone can successfully quit by 2 to 3 times. But even when I'm talking about the medications, ideally we want people to have the benefit of both counseling and medication, which gives them the greatest chances for success and is the best treatment plan. So this is just similar data from the Public Health Service Clinical Practice Guideline. If you look at the column for odds ratio, you can see that there's, through many studies, a lot of evidence that these medications work. And you see the odds ratio for patch, gum, inhaler, nasal spray, and bupropion are all around 2. So they double your chances that you'll successfully quit smoking compared with if you got a placebo in the trial. You can see Varenicline is the only one associated with a higher odds ratio of 3. So as a monotherapy, we can say that it is the most effective treatment when used as a monotherapy. In terms of nicotine replacement, you may be familiar with these products. Many of them have been available for quite a long time. So I'll just try to talk about some of the newer aspects. The patch, the gum, the lozenge, and the soon-to-be-released oral spray are all over-the-counter medications in this country. But again, I would recommend that you write prescriptions for patients so that they can try to get them with their state Medicaid at a reduced or no cost. If you're not sure what's covered in North Carolina, I would encourage you to check out this website, which is maintained by the American Lung Association, where they provide updates in that area. The nicotine inhaler and nasal spray are both prescription products, and they can be more expensive, which can result in less access. The themes for nicotine medication, sometimes people feel that they don't work, but we know that when we use them much more aggressively at a higher dose and in a sort of consistent way where people are dosing themselves every hour, they're much more likely to succeed. There's really no reason to rush people off nicotine medication, so make sure they use them for a long enough period. And at this point, we generally recommend about 6 months of treatment with these medications. There's really almost no one that you could think of who smokes who wouldn't be a candidate for nicotine replacement, because again, you're giving them one chemical versus thousands, and they're already used to nicotine, so there's very low risk in providing them with nicotine replacement. Nicotine has no drug-drug interactions, and that's why it's safe enough to be an over-the-counter medication. The FDA has been trying over the recent years to change the labeling of the way these medications are marketed and packaged, and some information for healthcare professionals to support that information and encourage people to use them more. So this was one that came out about 10 years ago, that there's no safety concerns when people smoke and use nicotine replacement at the same time. There's no safety concerns when people use 2 nicotine medications at the same time. And that's a very common strategy now that has better outcomes associated with it, and longer term use also seems to be safe. I'm obviously not a cardiologist, but there's been many studies done by cardiologists and published in cardiology journals, which indicate that these medications do not increase the risk for cardiovascular disease. whether you're talking about nicotine replacement or bupropion or varenicline, these medications are generally pretty safe and well tolerated. And the reason patients get cardiovascular problems is because they smoked for 40 years, and the benefits really outweigh the low risk of cardiovascular events. And according to cardiologists, we should be using them a lot more often. So the patch is fairly straightforward. It's absorbed through the skin. Many studies have shown for anyone who smokes a pack a day or more, it's very unlikely that they would get enough medication from the nicotine patch, even at the full strength 21 milligram dose. And for that reason, there's been lots of new strategies about doing what's called combination nicotine replacement, which is 2 medications at once. Many of the products are absorbed through the lining of the mouth, so-called oral nicotine. Although remember, the goal of the nicotine is not to end up in the stomach. If the nicotine ends up in the stomach, it doesn't reach the bloodstream very effectively, and it causes a lot of side effects like hiccups and upset stomach. So the way that these medications work is that the nicotine in the mouth, in the saliva, has to hang around for a long enough time that it's able to be absorbed through the lining of the cheek into the bloodstream. So there's a little bit of technique involved in using these medications effectively. You want to tell people don't eat or drink beverages except water when they're using the medicine. Most beverages are acidic and will reduce the absorption of nicotine through the lining of the mouth. And generally, when you use any of these products, they only give you about a half to a single cigarette's worth of nicotine per dose. So you could imagine if you smoke about 15 cigarettes a day, you might need on average about 15 doses to approximate the nicotine level that you were used to from smoking. Out of all of them, the gum is probably the trickiest, where you really want to instruct people to chew it rather slow and try to hold the gum in their cheek to maximize the nicotine absorption. The nicotine oral spray was approved last year, but has not yet hit the stores. I'm sure in part that has to do with manufacturing delays and COVID. This product, though, is not really new. It's been available in Canada and Europe for some time. The idea behind the spray is you shoot the spray into your mouth, and it is similar to the other oral nicotine replacement products. Because the size of the droplet is small, the idea is that you may be able to absorb the nicotine slightly faster in this product compared with others, which may give it a slight edge in terms of craving relief. But essentially, it's quite similar to the other oral forms of nicotine replacement. One concern potentially for people with alcohol use disorder is that the way the product is manufactured is that it contains a tiny amount of alcohol, again, less than a teaspoon in the entire bottle, but for the same reason that some people choose to avoid mouthwash because of the low levels of alcohol, some people may not want to use this product. I won't say much about the prescription products unless you have questions, because they tend to be more expensive and utilized less. We mentioned that when people smoke and use nicotine replacement at the same time, that there's really very little risk from that. In fact, some people actually would quit smoking if they just put patches on, even if they weren't motivated. Studies estimate that 7% of unmotivated people would quit just by virtue of wearing the patch. So we might think about them in terms of harm reduction, decreasing the enjoyment from smoking, and helping people to smoke less over time. Not much is new in terms of bupropion. We use it much in the same way that we use it as an antidepressant. We can never use it in people with seizure disorders because of the contraindication. Its overall efficacy is similar to nicotine replacement. Its effect is independent of depression, so it could be a great choice for a depressed smoker. But in fact, when it helps people stop smoking, that's independent of its effect on depression. Out of all the medicines available, it may have the least amount of weight gain associated with it. There's been tremendous increase in this area, which is studies and use of CombinationNRT, which is essentially recommending to patients that they wear a long-acting patch and then supplement the patch throughout the day with a short-acting form of nicotine replacement. This delivers a higher dose of nicotine than you would get just from one product and provides better withdrawal and craving relief, and is essentially associated with better outcomes compared to a single-dose nicotine and really has rapidly become the standard of care. The last treatment I'll talk about is Varenicline, which works in a different way as an alpha-4 beta-2 nicotinic partial agonist. What does that mean? Well, this medication was developed based on understanding of the biology of addiction and nicotinic receptors, which are located in the ventral tegmental area. When you smoke, of course, it activates those receptors and causes the release of dopamine in the nucleus accumbens, similar to other drugs. So when you use the medication Varenicline, it's also attaching to that receptor, but as a partial agonist has a slightly different set of activities. It partially stimulates the receptor, causing the release of a small amount of dopamine, not enough to be addicting, so Varenicline doesn't have any dependence liability, but perhaps enough to produce what's called tone or to prevent anhedonia. It keeps the receptor from going into withdrawal, so that's one of the effects of taking Varenicline. And because it has a strong affinity for the receptor, it blocks nicotine's ability to activate this system. So if you were to smoke a cigarette while you were taking Varenicline, you wouldn't enjoy it, and it would be acting sort of like an antagonist. So it has that variety of ways it works to help people to quit smoking. These are the most common side effects that have been associated with Varenicline in placebo-controlled trials. The most common one is nausea, and it's recommended that you take the medication twice a day with food to reduce the incidence of nausea. And because it's excreted by the kidney, there are no clinically significant drug-drug interactions in the liver. Because of concerns about the potential neuropsychiatric risks from this medication, a large study was done under the direction of the FDA. It's kind of a famous study now called the EAGLE study. It's the largest smoking cessation study which was ever done that included more than 8,000 patients. And the point was to really have a definitive study to evaluate the risk for neuropsychiatric side effects from Varenicline. So it was compared in a triple dummy design with bupropion and patch. So some people got Varenicline, some people got bupropion, some people got a patch, and some people got 3 placebos. Everyone used 3 medications so that no one knew which one they were receiving. This study on purpose included half of the sample, about 4,000 patients with known psychiatric illness, to determine if there was an increased vulnerability for neuropsychiatric side effects in that group. And these were stable outpatients with depression, anxiety disorder, schizophrenia, who wanted to try to quit smoking. This was what the study found. So similar to other studies, the overall success in quitting smoking was greatest with Varenicline. You can see to the far left in the non-psychiatric cohort, it comes out as almost 40 out of 100, which was shown in prior studies, and is better than bupropion or patch, which on average, the success is about 25 out of 100 in a variety of studies. So again, consistent information, and when used as a monotherapy, it is the most effective medication we have. If you look at the center part of the graph, you see this is the cohort of those with psychiatric illness, and you see that even the same trend is true, that we know for sure that even in psychiatric patients, Varenicline is the most effective treatment, significantly better than bupropion or patch, although that you see that the overall success in quitting is less, which is also true. So patients with psychiatric illnesses can quit smoking, but the overall success we see is lower than groups without psychiatric illness. All of those medication groups, of course, are better than the placebo groups, which essentially receive counseling alone. So that's the purple bars. Counseling alone can work, but you see when you add medication, success rates go up. The study was really evaluating all of these different neuropsychiatric side effects, and I would refer you to the numerous papers that have now been published looking at this data in great detail. But essentially, it was a comprehensive measure to look at the risk for neuropsychiatric side effects, including suicidal ideation, and essentially there was no difference between medication groups. So that is to say that when you have a study as large as this with 8,000 patients, it's not true that nobody had suicidal ideation. There were patients in the trial who had suicidal ideation in the study. However, the rates were equal, whether or not you took Varenicline or bupropion or patch or, in fact, 3 placebos. So the conclusion is that it cannot be from the medication. Although the real side effects associated with Varenicline in this study, consistent with the other slide that I showed you, included nausea, insomnia, and abnormal dreams. So based on that information, the FDA changed some of the licensing information package insert regarding Varenicline, removing the black box warning for neuropsychiatric side effects. And so now we have evidence that we have two potential treatment strategies that are really better than the others. And so there's been a lot of sort of reorganizing this information now into more of an algorithm and thinking about Varenicline or CombinationNRT really as our first line medication treatments, evidence that this is better than the other treatments and we should be offering patients the best option. Should we use medications for people who are not ready to quit? I would say yes. We know that these medications may help people to reduce their smoking over time, which would lessen their dependence and help them to be more successful quitting. In fact, studies have shown that people have a higher chance for successfully quitting over time if they're able to reduce at least by 50% or more and lessen their level of dependence. We should be using a lot more nicotine for temporary abstinence. I can think of lots of treatment settings where we have patients for more than 4 hours when they would be experiencing withdrawal from this drug, screening centers, emergency rooms, residential programs. We should be really providing a lot more access to nicotine to prevent withdrawal, even if it's for periods of temporary abstinence. And also this experience, if people have a positive experience with nicotine, that may help facilitate subsequent treatment or cessation efforts. And there's a few studies that have really shown that the impact of tobacco withdrawal is clinically significant. It significantly reduced agitation in a sample with schizophrenia in an emergency room. And experiencing tobacco withdrawal probably contributes in some inpatient psychiatric hospitals to people leaving AMA. There was a recent review of this idea, reduce to quit, in terms of helping people reduce smoking. Is that a viable option? Does it lead to subsequent quitting? And what the evidence seems to show is that reduce to quit is most effective when people use medications. So if people just try to go home and smoke less, they're very likely to experience significant withdrawal, which may undermine their effort. And they may not be able to reduce their cigarette smoking. However, there's evidence that when we give people medications, that they can be very successful in reducing their smoking and subsequent quitting. In fact, this was a study of Varenicline for a reduce to quit paradigm. These were smokers that came into the study saying that they didn't want to quit smoking, but that they were willing to work with the team to maybe try and reduce the amount that they smoked. Half of them got Varenicline, half of them got a placebo. They were instructed to go home and try to reduce their smoking by half as many cigarettes over a month, and then subsequent reduction goals to try to work to zero. And what you see is that the group that gets Varenicline is kind of wildly successful with very high rates of being able to quit, which were even sustained beyond the treatment period. So the use of medication can really greatly increase people's chances of quitting, even if they don't identify that they're immediately motivated to quit. This study was so successful that this was now included in the package insert, which means it's not considered experimental. It's even FDA approved that you could use Varenicline in people who are not immediately ready to quit, but willing to cut down. That's kind of a big change. What do we know about mental health populations? Well, some of this I've said. The treatments work and they tend to be well tolerated, although the overall success can be less for this group compared with populations without mental health problems. There's been many studies in the last 10 or 20 years of mental health populations working to try to quit smoking. Lots of evidence they want to try to quit smoking. No evidence that the effort worsens depression or psychosis. Again, no worsening of neuropsychiatric symptoms in terms of Varenicline. And there's also been a lot of modified counseling approaches, more intensive perhaps than what you would get on the telephone quit line to help people. What about studies in substance use populations? Well, similarly, the treatments work and are well tolerated. In fact, John Hughes did a lot of research in smokers with a history of alcohol dependence people with a year or more of sobriety and showed that these populations were as equally likely to quit smoking as any other smoker, which was a bit of a surprise because they had higher levels of dependence to tobacco. You might think that they would have reduced success in stopping smoking, but something about perhaps the experience of recovering from one substance gives them an advantage, knowing what to do to manage cues and triggers is in their favor and helps them to quit. As I mentioned, smoking, there's a lot of evidence now that people who continue to smoke during substance abuse treatment have a higher risk for relapse back to drugs and alcohol. We know that when people stop smoking, again, it enhances their overall long-term abstinence. And interesting work about Varenicline, since Varenicline is impacting the reward pathways in the brain, it has the potential to not only impact nicotine reward, but reward from other drugs. And there's been several studies that indicate that Varenicline reduces drinking in both animal and human studies. Just briefly, because we don't have so much time to go into this, I just want to make a few comments about e-cigarettes, or as they're called now, electronic nicotine delivery systems, or ENDS. The idea behind an e-cigarette is that the nicotine is heated, but technically doesn't burn. So typically these devices have a battery, they contain nicotine, and they have a heating element that heats up the nicotine when it's turned on. It produces a vape or a mist that the person ingests. So in general, if you said, well, these would have to be safer than a cigarette because they don't burn, they don't produce the combustion products of smoke that we know are toxic. That in fact is true. The mist itself, when analyzed in a lab, has been shown from some e-cigarettes to contain toxins, heavy metals, and carcinogens, but in general, the amount in an e-cigarette mist is about 1% of what you would ingest from cigarette smoke. So people think about it as a harm reduction product, although that's somewhat controversial in this country. One of the things that makes it hard to speak about e-cigarettes is that they're not really one thing. There's thousands of them, and they're constantly changing and not regulated in terms of sales or advertising. So you don't really know what you're putting into your body. There could be wide variation in composition. And if you use one of the mods form where you're using kind of this liquid, your e-juice, literally someone could be making this in their garage and selling it in the mall. So there's risk for contamination, and that's a risk as well. So the fact that there's no testing or regulation is of a concern. In the UK, they have taken a different approach where they have limited the sale to a small number of products. They're tested and regulated, and they're actually encouraging people to use them as a cessation strategy, but that has not been the approach in this country. There's a lot of concern. There's been a huge uptick, of course, in young people with these products, and we worry about that it could be a gateway to smoking combustible cigarettes as well as cannabis, and studies do seem to indicate that young people who use e-cigarettes are more likely than their peers to go on to smoke cigarettes and pot. And there's a lot of vaping culture that sort of puts these together in terms of vaping, THC, cannabis, and nicotine. That was related, of course, to the report last year of EVALI, or e-cigarette or vaping associated lung injury, which was sort of the pre-COVID news that people were having serious lung injury that required hospitalization. It was associated with 60 deaths. The cause seemed to be a contaminant in some THC-containing devices. Vitamin E acetate specifically seemed to be damaging to lung tissue. Most of the people who were involved in these cases were using THC products, but there were some people who reported vaping nicotine alone who also developed EVALI, so that's a cause for concern. And the prototypical patient was a young male often. So this was sort of a quick review about some of the ideas and updates with regard to tobacco treatment. It's the smoke that kills. The bulk of toxicity is in the smoke. we should really think about generally using words like treatment and approaching it as a co-occurring disorder where a variety of motivational interventions would also be helpful. We should think about medications. Nowadays, we use medications really for almost everyone, but in particular for anyone who is smoking in the first 30 minutes of waking up in the morning. We saw the data that Varenicline or CombinationNRT are two very good medication strategies that we should offer as first line. And behavioral health professionals, all of you, already have the skills to do excellent tobacco counseling. It's very similar to other substance counseling, and I have every confidence that you would be quite good at it. And that's it. I will conclude with that.